very important and relevant lecture to the Neuro-Palliative Care and the followers of this group. We have Dr. Benzi Kluger from Rochester, University of Rochester, New York, giving a talk on Neuro-Palliative Care through the paradigm of Parkinsonism. As many of you may know, he has done pioneering work in the area of Neuro-Palliative Care, especially a lot of published studies on Neuro-Palliative Care of Parkinson patients. So I invite you, Dr. Kluger, to start with your talk. Yeah.
All right, thank you. Okay, so I'm going to start my screen share. Okay. Everyone's able to see the screen, see my slides?
Yes. Yeah.
Great. Okay, perfect. Yeah, so I'm going to start by talking about the Neuro-Palliative Care as a subspecialty. And, you know, this has been talked about in one way or another for over 25 years, but it's really only in the last, I would say, 5 years that it's really been taken seriously. And actually, India and RUP has been, I think, one of the leading places of where neuropalliative care and neuropalliative care education has really started to take off. I'll share a little bit about my personal journey for people who haven't heard it. These are two sisters who I took care of who have Huntington's disease, Carissa and Juju. They got Huntington's disease at ages 9 and 11. Juju, the younger sister, I saw when she was 18, and she actually died shortly after I began seeing her. We had her on hospice, and she was comfortable. And her older sister, Carissa, was really an amazing person. She taught me a lot about who I wanted to be as a doctor. She was the Huntington's disease patient of the year. And I can remember clearly one time in clinic where she was having difficulty sleeping, and I asked her why she was having problems with her sleep. And she told me that she was afraid of dying in her sleep. And it was really at that moment that a light bulb kind of went off for me, that if I was going to help people like Carissa and people with Parkinson's and ALS and brain tumors, that I would have to kind of go beyond the traditional biomedical model, that we would have to bring in psychosocial support, we would have to bring in spiritual support. The fear of death is ultimately a spiritual or an existential issue. And I think that was really a pivoting and a turning point for my career into palliative care. So for the first half of this lecture, and we can go through this quickly and potentially do questions in between or do all the questions at the end, but just to understand the range of options and the training required for incorporating palliative care into neurology, and describe some of the advantages, limitations, and barriers to various models of implementing palliative care in practice. And the range of options for training and the models are not totally dependent on each other. And then lastly, we'll kind of wrap up with some opportunities for incorporating neuropalliative care into inpatient, outpatient, and community settings. As Roop may have shared with you before, we are in the starting phases of a new international society for neuropalliative care, and Roop can send around an invitation for our 4th annual Neuropalliative Care Summit, which is an international meeting. I think we have 80 people who have signed up at this point, but our mission is to raise standards of care for all people affected by neurologic illness. And I say this because if you have cancer, particularly if you have cancer in the United States, and you go to a cancer center, you're going to get a social worker, you'll have a chaplain, you'll have a summer camp for your kids, you'll have a book club. But if you have a neurologic illness and go to any center of excellence throughout the United States, you will not get any of those things. So I think as a neurologic community, it's really incumbent upon ourselves. It's not incumbent on palliative medicine. It's incumbent on us as neurologists to raise standards of care for people affected by our illness. And our vision is a world where high quality, person-centered supportive care is available for all people affected by neurologic illness. We really want to make this the rule rather than the exception. How do we get there? We need to think about palliative care, I think, a little bit differently than we traditionally have. So palliative care is not just a specialty. I would say palliative medicine is a specialty, but palliative care is also an approach to comprehensive person-centered care, and it's an approach that all physicians, all clinicians should incorporate. Palliative care is also a public health goal. And so if we're thinking about palliative care from a systems perspective, a patient of mine, Kirk Hall, actually wrote a great paper describing palliative care as a three-legged stool, where we need community organizations, which could include education, support groups. In Kerala, there's been some great work with community palliative care. We need primary care providers and neurologists to adopt a primary palliative care position. That unless that leg is strong, we could have the best hospices and the best palliative medicine doctors in the world, and we're not going to have great public health outcomes because patients are not going to be referred to them. And lastly, we do need strong specialized palliative care teams. This could include hospice in the United States. It includes palliative care. I think part of the idea here is that all of these legs are complementary. One is not more important than the other. We really need all three to have a system that can stand on its own. What is neuropalliative care? So it's palliative care for patients with neurologic illnesses. And I make the point that I think it is different than just palliative care for patients with neurologic illnesses. It's really a hybrid approach where we take the strengths of neurology and our intimate knowledge with the various diseases that affect patients with neurologic diseases, and we combine it with the strengths of people in palliative medicine. That I believe that palliative medicine by itself and neurology by itself will not really achieve our goal. Who's doing it? Neurologists, palliative medicine specialists, social workers, chaplain, advanced practice providers, and really all neurologists should be doing generalist level palliative care. So this would include being able to give a diagnosis with compassion, be able to discuss prognosis and provide a roadmap for patients, advanced care planning, referring patients to hospice and palliative care when it's appropriate, doing some basic symptom management for things such as pain. All of this would fall under the heading of primary palliative care. And this is just a statement from an article, again, from 1996. And I'm just highlighting here that it's imperative that neurologists understand and learn to apply the principles of palliative medicine, particularly as many patients look to us as their doctor, their main doctor. In the United States, palliative care certification has evolved in neurology. In 2006 was actually the first year that neurologists could be board certified in hospice and palliative medicine. And in 2012, fellowship training began to be required. Prior to that, people could grandfather in if they were in practice. And in 2014, there were 51 neurologists who were board certified. 2019, there's 63. It's continuing to grow. We actually trained our first specific neuropalliative care fellow last year. And there are 300 members of the American Academy of Neurology who self-identify as neuropalliative care, and I would include myself among those numbers. There's also increasing opportunities to pursue specialty and generalist training. I think this FINE course and other work that Roop is planning in India is amazing, and we will be using and talk a little bit later about EPEC, which is Education in Palliative and End-of-Life Care, based out of Northwestern, that we are completing this month, a neurology adaptation, which will have 26 modules and will be free and available to anyone interested in pursuing that training. As far as career paths that people can choose, people can be a neurologist who specializes in palliative medicine. Neurologists can practice both neurology and palliative medicine. Palliative medicine providers may decide that they want to focus on neurologic disorders, and that's certainly a welcome bridge. People can become a neuropalliative care specialist like myself. And I think a minimum, and I hope an aspiration for everybody on this call is to become a neurologist who practices high quality primary palliative care. And as you can see here from the asterisk, that some of these options require a palliative medicine fellowship or additional training such as a master's degree, but not all of them. In the United States, Palliative Medicine Fellowship is a one-year program. It can also be completed part-time over 24 months. It's acknowledged by our Board of Neurology. There's 122 fellowship programs throughout the United States, 383 slots. And we are working on creating neuropalliative care fellowships. Currently at Rochester and at Colorado, we have a track that neurologists can do where they would have more intensive opportunities for neuropalliative care, but it's not a separate specialty from palliative medicine. These are some of the highlights of the curriculum that may be additional to what palliative medicine doctors or primary palliative care. So it includes very intensive training in pain, in the use of opiates, and management of non-pain symptoms, dealing with neuropsychiatric and medical comorbidities, psychosocial issues such as grief and isolation, spiritual issues, providing expert care around death and dying, including taking people off of ventilators, for instance, with ALS, expert communication, running family meetings, bioethics and legal decisions, supporting family members who've lost a loved one with bereavement, working with an interdisciplinary care team, and hospice, which is really specialized end-of-life care. So if people want to go the route of a neurologist specializing in palliative medicine, we can talk about fellowship training. I know there are other options. In the US, there's actually now a master's in palliative care that also can be done at a distance. I think it requires 4 in-person meetings. And I know there are other options within India that some people have or are considering pursuing to get specialized training in palliative care. Career path 2 would be a neurologist who practices both neurology and palliative medicine. And the training requirements would be essentially identical. Some people will choose to do additional neurology subspecialty training. One career choice, for instance, that I've seen pretty frequently is people doing neuromuscular fellowships and taking on a palliative fellowship as well, so that they can really provide expert care for patients with Lou Gehrig's disease or ALS. And career opportunities with this combination include doing both general or subspecialty neurology practice, doing neuropalliative care, serving as a palliative medicine physician, and more often than not, people do a mix of these various career paths. There are certainly benefits for a neurologist to be on a palliative medicine team. They can offer disease-specific knowledge for goals of care. In Colorado, where we had 2 neurologists who also had palliative fellowships, they were usually helpful to their palliative care colleagues when difficult neurologic patients came along. They can help with interpreting neurologic signs that may be early indicators of progression that people who aren't as intimately familiar with the neurologic exam may miss. They can incorporate neuroimaging results into discussions, which can be very helpful, particularly with people with brain cancer or with large strokes. And they can lastly assist with providing end-of-life care for patients with both catastrophic intracranial processes as well as catastrophic neurologic issues such as status epilepticus. A third career path is a palliative medicine specialist with a focus in neurology. And I don't know everybody on the call, but if there are palliative medicine specialists on the call, that it is possible to do additional training in neurology. And in fact, our pediatric Neuro-Palliative Care program at Rochester is going to be run by a palliative care fellow who has a very high interest in neurology and will be getting additional training, mostly informally, by myself and others to sharpen his pediatric neurology skills. So for palliative medicine specialists, they can also join a neuropalliative care practice. They can become embedded in neurologic clinics. And then there are the other more traditional routes, such as being a hospice director or other things like that, but potentially being a hospice director of a hospice or end-of-life care or community palliative care that really specializes and welcomes neurology patients, which is not the case for all palliative care programs. And the benefits of having a palliative medicine specialist on a neurology team are multifold. So palliative medicine specialists can really help with complex symptoms such as pain. They can help with complex goals of care discussions, provide whole person assessments, and assist with transitions as people near end of life, as well as providing coaching for people who really want to sharpen their primary palliative care skills. And I know I benefited at Colorado as I learned palliative care from our palliative care colleagues. A career path 4 is becoming a neuropalliative care specialist. And this does not require palliative medicine formal training. I've never done formal training. Janice Miyasaki, Bob Holloway, other people who I would consider leaders in the field have not done palliative care formal training. Nonetheless, we have all been very deeply involved in palliative care. and are very practiced and spend a lot of time reading, thinking, teaching, and taking courses in this area. And I just listed several of the courses that are available if people really want to whet their appetite and get started learning some of these skills. I'm also happy to email or talk offline if people are more interested in pursuing this area, because I think that it is a great need. And I think really second to oncology, and as people age and as the future changes, I think it will even supersede oncology as the predominant need for palliative care. There are also additional opportunities for research, for being a leader, for education, and for advocacy. Lastly, and I think the real heart of this course is neurologists practicing high quality primary palliative care. And this could be anyone who's completed neurology residency or neurology subspecialty training. And people can get additional training in primary palliative care through the resources described in the last slide. And I think the opportunities are you can enhance your own practice. You're empowered to handle a greater range of suffering and greater range of situations. It provides you with tools to enhance patient and family outcomes. And I think, certainly for myself as I got into this, but for other people who I've trained, I think it can really enhance one's career satisfaction and the meaning of the work that you provide. So shifting gears from training to putting this into practice, there's kind of four main models of neuropalliative care. And I would also say that these models are complementary. These are not competing models. So, and I think in the ideal public health system, we have a mix of all four. The consultative model, this doctor is saying there's no easy way I can tell you this, so I'm sending you to someone who can, is that we refer patients for specialized palliative care. And this is a kind of a ready-made model that it is the goal of the neurologist to identify palliative care needs and then refer that patient to a palliative care specialist, whether that be inpatient, outpatient, home, or in the community. And the advantage is that there are not so many training requirements for neurologists. There's less time investment and care activities, and there are available expert specialist care. Some of the limitations are the care tends to be disjointed. There may be gaps in cares. This certainly does not cover all of a patient's and family's needs. For instance, getting a diagnosis with care and compassion. And palliative medicine specialists don't always have the requisite neurology expertise to fully meet our patients' needs. There are also workforce shortages in palliative care. I know there's many areas of India as well as in the United States where palliative care is not available even to patients with cancer. In Model 2, primary palliative care, a primary care physician or a non-palliative specialist such as a neurologist provides palliative care for patients. And this could include goals of care discussion, advanced care planning, symptom management, psychosocial and caregiver support. There's a great article in this Neurology Clinical Practice from 2016 talking about neurologists as primary palliative care providers. And these are some of the basic skills that would fall under that heading. There's a shortage of palliative care specialists, and this is one reason why, particularly actually even during the COVID pandemic, there's actually an even greater push for making neurologists and primary care physicians frontline palliative care providers. Advantages are that we can address a lot of the palliative care needs of patients at the time and the place where they generally present. It provides better integration of care, improves timely recognition and management of important issues, actually improves relationships and communication between patients and providers. Limitations are that certain issues may be beyond the scope of a provider's skill set, such as intensive grief counseling, may lead to an underestimation of the value of palliative care, and so we really want to continue to refer patients to our palliative care colleagues when they need them. And there may be some advantages of separating palliative and disease-specific care. For instance, with my neuro-oncology colleagues, they find it really helpful for me to be there and that they can then focus completely on the patient's brain cancer and how to treat it. And then I have a separate and independent role in talking about goals of care, and it creates some less role confusion for patients and families. Barriers to this are that it currently is not very well addressed in most neurology training programs, and that's something that we're working very hard to change. It requires a commitment for providers to self-educate. It may be challenging to get local and practice support. It may be challenging to get reimbursement for additional time spent in these activities. And one of the things I would say around this is that sometimes we need to just switch our hats. As an example, if I'm seeing a Parkinson's patient and they need DBS, I will set up a special appointment to talk about DBS because that's a very detailed conversation. Similarly, if I need to talk about advanced care planning, I'm not going to squeeze it in between medications for tremor and something else. I'm going to set up another visit to really go into these things in depth. Third model is to integrate subspecialty palliative care. And so for certain illnesses such as ALS, multiple sclerosis, stroke, neuro-oncology, there are some team-based clinics, and it is sometimes possible to bring a palliative medicine specialist on the team or a neuro-palliative care specialist on the team. Some of the advantages of this is it actually, I think, improves the team-based care. It helps integrate it better. It helps it focus more on patient and caregiver goals. Some of the limitations are that it only addresses these illnesses that are seen in multidisciplinary clinics. It's fairly resource, space, and time intensive, and it can sometimes be overwhelming or fatiguing for patients and families. It also may be challenging to provide truly interdisciplinary care with palliative and disease specialists having an equal say in how decisions are made. And lastly is this emerging field of neuropalliative care, where specialist neuropalliative care physicians may help with neurologic and neurosurgical conditions. And it could be led, as I mentioned, by a neurologist or palliative medicine specialist. And this person can also serve, and we're doing this very actively at Rochester, to provide education and guidance for other people in the practice who want to improve their primary palliative care skills. I think some of the advantages of this approach is it provides a central resource. I think just as any neurologist can help take care of epilepsy patients, it's helpful to have an epileptologist for more difficult cases. I would use the same analogy for neuropalliative care. The neuropalliative care specialist can also create a bridge between, say, neurology and hospice. Limitations are similar to many of the other models. So it requires palliative medicine fellowship or a very committed clinician. And so there's going to be workforce issues until we develop a new workforce. There is certainly no way that one person or two people or even a whole section is going to be able to handle the volume of palliative care needs for the population, because every single patient with a neurologic disorder at some point during their disease course will need palliative care. And so this is no substitute for everybody being responsible for primary palliative care. And it also requires some cultural adaptations that when I first started at Colorado and now at Rochester, there were some neurologists who were threatened by it, didn't understand palliative care. And over time, with education, with some of their patients coming to see me, they've lessened their fears. Other barriers is that ideally it includes a team, and it can sometimes be difficult to get social work, spiritual care, and counseling. It may be difficult to get institutional time and support and space. And as I mentioned, cultural issues may interfere with ideal communication across providers. So just to talk about neuropalliative care in a few contexts, inpatient, this could include consultations where a palliative care team sees patients and caregivers on the neurology service or the neurologic ICU. And I was just in a conversation today about being more involved in our neurologic ICU, particularly as the COVID crisis has heightened concerns and has created social isolations for a lot of patients. This can also be done in a primary palliative care or a neuropalliative care model. And I think there are many opportunities for neurologists to improve their conversations around end of life and around some of the crises that happen in the hospital. From numerous studies, we know that these conversations are happening too late. For patients who are consulted, 70% are unable to communicate. Over half have chronic neurologic illnesses. And so one of the big lessons, I think, from inpatient palliative care is that we need to do better proactive palliative care as an outpatient to avoid unnecessary hospitalizations. Outpatient neuropalliative care, which has really been much of what's informed this talk, can be integrated into other clinics. It can be integrated even into the care of an individual patient. Ideally, can benefit from an interdisciplinary approach, but that could also be multidisciplinary. It could also involve having a process for referring patients to key community resources. And there is evidence now that it may impact important outcomes such as symptom control, advanced directive completion, and place of death. And lastly, community neuropalliative care, and I would actually put telehealth in this, which is a very active and growing field of research, allows us to do virtual house calls or actual house calls to provide care in the home. And I think this is increasingly important as patients become more and more disabled. Oftentimes they stop seeing their neurologist because they're not getting much out of the visits, and also because it's so difficult to get to a neurologist. So the more that we can reach out to these patients, the better care we can provide and the less abandonment. So I will defer to Roop as to whether we want to do some questions in between, or if I should just jump into the next talk and then do all the questions at the end.
Roop, you want to tell us how you want him to go? I think Roop may not be there right now. So maybe we can go on. I mean, it was a good elucidation of the training part and the different ways it can be integrated. So I think that's very good. Maybe we can, Roop, should you go on to the next talk?
Yeah, of course. We'll take everything at the end.
All right.
Okay. All right. Let me fix some things on my computer here. Get rid of this guy. To work.
Do we have the questions right now, or people are typing, or we will have to announce that they can ask the questions?
They should type in the questions.
Yeah, I think.
So far, sir, we don't have any questions.
Okay, right now.
Okay. Yeah, if questions come up, let me know, and we'll jump into next topic. Palliative care in Parkinson's disease and related disorders. And so for this one, I'd like to talk just briefly about the research journey for Parkinson's, because I think this is applicable to epilepsy, to brain cancer, to stroke, that our first step in moving towards this randomized controlled trial that I'll describe was understanding the palliative care needs of people with Parkinson's, understanding their preferences for care, so really developing a model that was patient and family-centered. We then did some quality improvement projects, and I'm happy to talk about how we did those, but they involved figuring out who should be on our team, how long should visits be, what issues should we address, and we really tried to refine our intervention before going to our first clinical trial. We did a comparative effectiveness trial where we compared this to standard care, and we are currently in the process of doing other pragmatic trials to see if we can implement and disseminate this model of care more widely. So my objectives for this portion of the talk are to understand why palliative care is so important for Parkinson's and related disorders, talk briefly about how to deliver this diagnosis with care and compassion, providing a roadmap for people living with Parkinson's, how to systematically recognize and treat common non-motor symptoms, anticipate common psychosocial concerns, and to refer to hospice when appropriate. So just as a brief overview, as people on the call may know, Parkinson's is the second most common neurodegenerative illness after Alzheimer's disease. It affects almost 2% of people over age 65. It's the 14th leading cause of death in the US, 18,000 deaths in India. And I bring this up because a lot of times, even neurologists will say that people don't die of Parkinson's, they die with Parkinson's, and that's simply not true. People can die of Parkinson's. It's not a benign illness. 75% of people with Parkinson's living 20 years or longer will develop dementia. 90% of people have one or more, actually on average 8 non-motor symptoms, including pain, depression, and fatigue. And there are very high rates of hospital deaths, at least in the United States, and very low rates of hospice use. And I think that's because we're not thinking about Parkinson's as a terminal illness. Related disorders include multiple systems atrophy, corticobasal degeneration, PSP, Lewy body dementia. All these diseases very similar in terms of their palliative care needs, and I would say almost interchangeable with advanced Parkinson's disease in terms of palliative care needs, but they tend to have a worse prognosis, more rapid progression, and less options from normal medical and surgical care. Some key aspects of the palliative care approach is that we want it to be compassionate and person-centered. And I say person-centered to distinguish it from a biomedical model, which is really disease-centered. So we want to focus on the whole person, including their emotional, their spiritual, and their social being. We need to provide expert communication and expert education to our patients. And in particular, we need to empower them to be able to help us and to activate them to help us in making decisions that are going to be concordant with their goals and their values. We need to be very systematic about assessing and treating symptoms. Atul Gawande wrote a great book on checklists. And while I was initially skeptical, I found through the course of our randomized controlled trial that checklists are really essential. That if I didn't have checklists, I would miss depression, I would miss pain, I would forget about doing advanced care planning. And in fact, there's a good deal of literature that shows that neurologists about half of the time miss things like depression and pain in patients with Parkinson's. We need to discuss goals of care almost from the time of diagnosis to help people prepare for the future. And we need to really broadly support quality of life. In palliative care, there's this concept of total pain, but I would go beyond that. And most of our quality of life measures measure things from 0 to -10. And I think we need to start thinking about things from 0 to +10. So how could we promote things such as growth, such as meaning, such as joy for our patients? And when we start thinking about the positive side of the equation, we find that we actually have more to offer. We can offer more in the way of hope, more in the way of ways to provide choice and empower people, despite the fact that we cannot cure their illness. And even at the end of life, there are things that we can do to support joy. For instance, holding hands, looking at a sunset, eating more of your favorite food, determining our attitude every day, determining how we want to grow through this illness, how we want to be a role model for our children and grandchildren. So all these would fit under this approach. So what are the needs of people with Parkinson's disease? First, to say that there are high palliative care needs and they're similar to patients with cancer. I think Roop will have all of these slides, and I've provided references for the assertions that I'm making. Parkinson's patients and their caregivers have unique needs that differ from patients with cancer. And even in areas where they have similar needs, such as pain, the causes are very different. Palliative care needs contribute to quality of life, even when we control for motor severity and depression. So if our goal is to optimize quality of life for our patients, we need palliative care. And patients across the board prefer proactive discussions. There are studies that show that they don't want, quote, palliative care. They don't like the term palliative care, but they do want those services. So if we call it supportive care, if we say we want to offer you an extra layer of support, if we say that we have a team that can help you with these other things, people are hungry for it. They just don't want to hear the word palliative care, which is sometimes associated with end of life. In qualitative studies, we found that patients with Parkinson's have a strong need for psychosocial support and guidance from the time of diagnosis, and this is also true for their families. Parkinson's has a significant impact on identity and personhood. Another area where having a counselor or other people can be helpful. Family caregivers absolutely need attention, and if we don't support them and they burn out, that's going to adversely affect our patients. Patients tend to be, in the United States and I think also in India, may be wary with disclosing information to physicians. They may not feel that physicians want to hear about their difficult emotions, planning for the future. And so we need to actively ask about that and welcome that information. And as I mentioned, patients and caregivers are very open to this approach. So I already talked about the importance of calling it supportive rather than palliative care. And with Parkinson's, we really need to be proactive. So if we want to meet end-stage needs well, we need to start at the time of diagnosis. This comic says, do you have an idea for your story yet? No, I'm waiting for inspiration. You can't just turn on creativity like a faucet. You have to be in the right mood. What mood is that? Last-minute panic. And I think that in a nutshell is our current system of dealing with palliative care and end-of-life issues with Parkinson's patients. As I'm sure a lot of us have seen with Parkinson's and other neurologic illnesses, that these challenging conversations tend to happen in the hospital. And they tend to happen with the patient's family because the patient is no longer able to speak for themselves. When we think about integrating palliative care, we really want to start at the time of diagnosis. And as you can see in this slide, which could be Parkinson's, could be Alzheimer's, could be almost any neurologic illness, the time of diagnosis is actually a time of very high palliative care needs, that people are adjusting to these changes in their life. And then over time, if they lose their ability to drive, needing assistance with dressing, have infections, that their palliative care needs will rise. But we need to keep in mind that at any point during their disease process, that there may be triggers that suggest that we should adopt a palliative care approach. We need to make a diagnosis with compassion. There's a great qualitative paper on this called Dropping the Bomb. I think as neurologists, we often feel that a diagnosis of Parkinson's is good news. And I think to us as neurologists, it is relatively good news. It's better than ALS, it's better than a brain cancer, it's better than Alzheimer's. But to the person hearing that news, it's not good news. That person now has an incurable diagnosis. And so we need to make sure that we are very compassionate and understanding when we give this diagnosis. And I think one of the key things with doing that is to allow people a time to adjust to having that diagnosis and doing quick follow-up, perhaps after a few weeks or a month, to ask questions and to get additional support with that news. Patients want a roadmap for the road ahead. I think a lot of doctors feel reticent to talk about the future because we don't have crystal balls and because we don't want to take away people's hope. But what we've found and what patients have told us is that if they have a clear roadmap, if they know what's ahead, if they know where they are, if they know what to look for, if they know what choices they may have to make, that they feel much more confident and they actually engage in life in a fuller manner. Patients may have difficulties coordinating care. I think this may be potentially worse in the United States where there are more care options, but patients are often overwhelmed. They ask us all the time, why don't my doctors talk to each other? And so as primary palliative care providers, it's incumbent upon us to help patients with this and as much as we can to talk to primary care providers or others to help coordinate care for them. There's a number of medical and psychiatric symptoms, and I'm happy to answer questions about the management of these. There are a number of resources on them, but the bottom line is that these non-motor symptoms, particularly things like pain and depression, have an overwhelming impact on patients' quality of life, and other issues such as dementia are leading causes of disability and in the United States, nursing home placement, and in India and throughout the world, cause of death and caregiver distress. Pain in Parkinson's disease may be neuropathic, and in fact, there's a higher rate of B12 and folate deficiency, so it's good to check for those things. Muscle cramps and rigidity are very common. Magnesium at night can help with that, as well as constipation. Dystonia is a common issue, which can be helped with Botox and physical therapy. There's orthopedic issues, such as frozen shoulder. And then other non-motor symptoms, such as constipation and bloating, can also be a cause of discomfort and pain. Regarding sleep and fatigue, it's important that we sort out things such as insomnia from medication issues at night. Sleep studies should be considered, as sleep disorders like sleep apnea are more common in Parkinson's. And fatigue may happen independent from sleep issues. Energy management strategies and mindfulness can be used, as well as stimulants such as methylphenidate. Regarding psychosis, it's important to start to find out if these are disabling or distressing versus benign. Are there secondary causes? And I would say one of the most common are dopaminergic medications and dopamine agonists in particular. Quetiapine or Seroquel can be used at a low dose. Pimavanserin, which is a newer medication, you need to be cautious about in that it can cause worsening psychosis. And clozapine or Clozaril is a great medication, except that it takes increased monitoring because of the risk of agranulocytosis. Prozac is not the answer for all of our patients' problems. This says, can we up the dosage? I still have feelings. So going beyond depression and anxiety, we need to recognize grief, guilt, anger, frustration, loneliness, demoralization. And the way to treat these is not to pathologize them, but to provide additional support, for instance, with counseling and support groups. Spiritual and existential issues are very common. It's one of the reasons we have a chaplain on our team. Patients oftentimes have a greater fear of death, a greater fear of being dependent on others, of being a burden to their family than they do even of death. So again, these are great sources of distress and things that we want to proactively address. Advanced care planning is very important and is now recognized as a quality measure to be done yearly by the American Academy of Neurology. When we don't do advanced care planning, patients are more likely to die in the hospital than they are at home. And waiting for the right time means these conversations happen without the patient's input. There are also some calls to make advanced care planning more disease specific. I like with Parkinson's patients to use the example of pneumonia and ask them questions such as your disease progresses, is there a point at which you would no longer want us to treat pneumonia? For instance, if you're no longer able to read or converse with your family, if you're no longer able to be a father or a grandfather in a way that's meaningful. So various people have different lines, but those kinds of conversations early can be very helpful to not only us, but also to their family, who can more honestly be their voice as opposed to their decision maker. Goals of care go beyond advanced care planning. So it's important to ask what their life was like before Parkinson's disease. What are their sources of suffering? What opportunities for joy are there? When I have conversations with people and I find out about their life in advance, it actually makes advanced care planning and end-of-life conversations a lot easier. Actually, just this week, I had a patient who was a very social person at 80 years old. He was still working 8 hours a day in a market and in a deli. And he was clearly somebody who would not want to be in a nursing home and would not want to live in a situation where he needed constant care. Hospice or end-of-life care, these are some of the red flags that I see that may prompt further discussions and may be referrals to palliative care in the Indian context. This includes weight loss with or without loss of appetite, dysphagia, particularly for liquids, withdrawal from activities, accelerating disability. So I'd like to call out that in neurologic illnesses, decline is rarely a straight line. Patients will have plateaus and times of dropping, but when we start to see things accelerate, that's really a time where I prick up my ears and may think about hospice for my patients. If patients are having recurrent hospitalizations, particularly for things like pneumonia or UTIs or falls, worsening dementia, and then lastly, loss of the will to live. So very severe withdrawal would all be times where I would start preparing the patient and the family for end of life. So how do we improve models of care? We can do nothing at all and hope something magical happens, or we can try to push for change. And this was a study that was published in February of this year, where we looked to see if integrated outpatient palliative care compared to standard care improved patient and family outcomes. So this is kind of a model of our current system for Parkinson's disease. We have neurologists who help the patient with their motor symptoms. We have primary care providers helping the patient with hypertension. Nobody's looking after the caregiver. And it's really up to the patient and the caregiver to figure out their own resources for advanced care plans. In the United States, more often than not, this is done by lawyers than doctors. And it really shouldn't be that way. And so the outcomes we see in our current system with the current gaps that we have is good motor symptom control, fair 50% of the time we do non-motor symptoms such as depression, and we do generally a not very good job with advanced care planning, end-of-life care, caregiver support, or other needs. And so our hypothesis was if we added an outpatient interdisciplinary palliative care team that specifically focused on palliative care issues such as non-motor symptoms, nutrition, home care, caregiver support, spiritual well-being, and that we had a team to do this, that outcomes would improve across the board for this person-centered model. And this is in fact what we found. So for the quality of life of disease Alzheimer's, which is what we use as our primary outcome measure, there were significant improvements at 3 months, and these were sustained throughout the study. For the Zarit Burden Inventory, which was our measure of care burden, that also improved, and as you can see, improved even greater at 12 months, and I suspect would have that would continue to widen. One of the things that I've found in my clinic is that as patients' disease progresses, that a greater percentage of our care and a greater percentage of the benefit of palliative care is really for the care partner more so than the patient. Other important study results was that we had a significantly improved symptom management, a greater than 7-point improvement on the Edmonton Symptom Scale. Grief or sense of sadness related to loss in life was significantly improved for patients in palliative care. The Parkinson's disease healthcare related quality of life was a trend towards improvement, and surprising to us, motor symptoms were significantly improved in the palliative care group, and I think that's because they were more engaged with exercise and other aspects of their life. Regarding qualitative results, patients felt an improved sense of guidance. They felt an improved sense of support and clarity. And what we found and what they told us was that difficult conversations did not lead to anxiety, did not lead to a loss of hope, but in fact led to improved engagement with life, a sense of relief, and increased hope that they would be able to live out their years in a way that was meaningful to them in a way that they were connected with their loved ones, and in a way that they had a choice of how they found joy. We are currently doing a study and are about 18 months away from finishing a study of community-based palliative care, where we are doing trainings just like we're doing today to teach neurologists about palliative care, and then using telehealth to provide team-based virtual house calls for our patients. And again, the study is designed in a pretty similar way as the one I just described. And our hope is that this model will allow us to provide high quality palliative care and achieve the same outcomes we did in our academic team, but do it in a less resource intensive way and do it to patients in the community. And I think this model of care may actually have great applicability to India, where there is a shortage of palliative care providers, a shortage of neurologists, and a lot of patients who have great distances that they need to travel. This is our study design. So it's the spoke and hub model, where we have a hub where we have our core team, and this core team is supporting various practices. In our case, 18 community practices around Colorado, Wyoming, and California. But we could imagine using a similar model to support primary care physicians, to support nurse practitioners or others in meeting all the needs of their Parkinson's patients. So with that, I think we have about a little over 10 minutes remaining, and I'm happy to field any questions that we have or open things up for other discussion. Thank you.
Yeah, hi. So what I'm going to do is, I'm going to be sharing my screen because, yeah, there it is, share screen. Put this on. Yeah, here. So can I ask Rajendra and Param to take this on? I'll get out of the way. I'll just move on once you're ready to come on.
All right. Yeah, go ahead. So
this is a comment from Sudhir. Yeah, this first is a comment from Sudhir.
I think the Benji described very well the holistic approach or the comprehensive approach on or a team approach for caring of these patients, whether it's right from the start of the illness, explaining the diagnosis. In fact, one of his talks earlier, he whenever you disclose the diagnosis of Parkinson's disease, that is the right time to explain and start palliative care from, and that's a continuum of the care. So I think if you combine a good neurologist with the palliative care skills, it becomes a caring doctor. And it's not only the now the concept of a doctor as a doctor, but as a healer also. If you read a lot of literature is coming up, doctor as a healer. So if you have all these combined skills in a good neurologist, I think that becomes a caring doctor.
Can I add a little? Yeah, very nice, Raj. Maybe we don't have to have a single model also. As you said, it can evolve over time. Right now, in many neurology setups, we don't have PAL care physicians. So maybe initially the neurologists have to train themselves a little bit into PAL care. And then over time, when we have PAL care people, the model could change to a collaborative model. So depending upon place to place, I guess we'll have to fine tune our starting models.
Benzi?
Yeah, I agree with both of those comments. Yeah, to Parm's point, I think even in Colorado and Rochester, our models have evolved, as I think all neurologists to some extent, may have some palliative care strengths, and so I think palliative care, just provides us with some tools that allow us to really connect into, I think for most of us, why we got into medicine in the first place. So it gives us tools to provide greater support, as Dr. Amija said, to the whole patient, and not just a sole focus on disease and medications.
I just want to add 2 points actually. This is again Benji's word that palliative care should be replaced by the word sportive care. So that gives a different dimension to the holistic care of the patient if you call it a sportive care in addition to your clinical treatment. And the second point why I would just want to add is the need of the caregivers. So that is also equally important. We are focused right now on the patient and the problems faced by the patients and their well-being. But the caregivers are also equally affected by the journey of the patient right from the diagnosis till the end. And we need to address those issues as well.
Absolutely, Raj, especially when we don't have hospice care much in our country. So almost all of the caregiver is done by the family or other people along with that. So that's a very valid point and important one.
Right. So, Benzi, we've spoken about this, the way Neuro-Palliative Care in Kerala. Would one of you, Rajendra? I mean, or should I just speak it? In Kerala,
I'll just take over. This is the Kerala model we are talking about, where the palliative care is very well established as compared to the other parts of the country where we are still in infancy. So their model is provided by the community-based, volunteer-led, and the supportive group led by Dr. Rajgopal. And the experience from there is about 50% of their burden is neurological related things. And that has been pretty successful. And that model has its own advantage and maybe few disadvantages from the other parts of the country, because Kerala is way ahead in terms of literacy and the very well established primary health setup there. That even their handling of COVID-19 shows that they are very well experienced in handling these crises. The first case of COVID-19 was reported in Kerala, and Kerala is the first state to, now they have done very well in terms of having a flattening of curve, or I don't think they have any case in last few days. So I think they have done very well, and their model of community palliative care, it's not only confined to neurology, I believe. It's confined. It was started with the oncology and then has extended over to the neuro-palliative care. But that model is one thing which Benji also described as one of the models of care, which I'm not sure whether you have, Benji, any data on head-to-head studies of community care versus consultative care versus integrative care. Not yet, but I'm sure that it will come in literature.
Yeah, there's I don't know if you're familiar with her work. There's a woman, Jory Fleischer, who's now at Rush University, was at NYU, who's been doing a lot with community-based palliative care in the United States. Thus far there haven't been head-to-head comparisons, but I think head-to-head comparisons in some ways misses the point that I think we really need to start thinking about things as complementary. And that we want to find the right care for the right patient as opposed to finding which one's the best. Because I think for some patients in some situations, community-based palliative care is going to be superior. And for other patients, I think particularly early on in their journey, or if they're in an urban area, that they, the outpatient palliative care model or a telemedicine model may be better. So I think the idea of having competing models is less powerful than the idea that we use complementary models. And as is the case in India and even in the United States, there's some very rural areas in the U.S. Where certain models may work better based on the resources that we have there than other models. So I think we need to be kind of flexible and not dogmatic as we approach it.
Param, the next one is this: how do you train in neuro-palliative care? So,
you guys answer. I'll leave it to you. Yeah.
You are the best person to
answer that. Yeah.
No. So, Benzi, would you like to speak a little bit about
from the Indian perspective, rather than from the US, which have explained different 4 models of training and the development of palliative services. But from the Indian perspective, what is the best one?
So as of now, for palliative care, you can actually do courses which are largely online. So Dr. Rajgopal's group runs a fairly well-regarded course. The Indian Association of Palliative Care does that. And there are shorter courses elsewhere too, but these are for palliative care and these are oncology focused. Of course, they'll give you the basic skills, but we've been realizing that and the other thing is that neurologists, they tend to get a little put off by too much of oncology work because that's not what they're going to be addressing. So I felt the need for a dedicated neuro-palliative care course. And Benzi can speak about that. And for somebody who wants to go beyond, at some stage, we probably will have an MSc in palliative care out of India. Right now, the palliative care professionals who are getting trained in palliative medicine are getting their MScs from abroad, from Cardiff University. There's one at Colorado also. But those are hugely expensive, although you get scholarships, but they're expensive. So we need to have an MSc in palliative care in India. But that is in the future. So in the meantime, Benzi, would you like to speak about epic neurology? I know we are still in the planning stage.
Yeah, well, we could both talk about it. So as I mentioned earlier, the education in palliative and end-of-life care neurology adaptation is going to be rolling out at the end of April, and we've talked about actually making it a course over the course of a year beginning in January of 2021. And I think actually will be a very powerful way for people who want to kind of take neuropalliative care to the next level. Our current plan would be to take 12 of the most important modules and to give people a month to really get into depth with that module, to read the associated chapter, to answer some questions. And then in September, people would have an option of either in India with Roop and colleagues, or in Chicago in the United States with Josh Hauser and the EPEC group to do a more intensive in-person training, in particular to both not only do a more intensive communication training, but also to learn some of the techniques of training others in palliative care. And I think teaching palliative care is one of the best ways to learn it. And I know I've certainly sharpened my skills as I've worked as an educator.
Right. Param, would you like to take the next?
So the next question is in India, especially in Hindus, and I believe in many other religions too, apart from Christianity, you don't have a clergy that can work as chaplains for the patients. So how do we address these needs for any patient? Oh, that's your question. Yeah. Okay. Yeah. So I don't know, Roop. I mean, yeah, I agree with you. We don't have that system of people coming to the hospital and talking to the terminal patients. And I guess this one will have to be answered over time with consultation with the patients. What kind of spiritual connection they are looking forward at that time do they have? Because we have, you know, a lot of faiths which people follow. Even in the faith, there are subcategories, and everyone has their own way to follow faith. So this would have to be a consultative practice along with the patients as we go on with our neuropal care, that what people and how and what time and at what place would they want to. I mean, that's my thought. Any other ideas on that?
So Benzi will probably tell you that they have as much diversity there. So how do they address that?
Well, there's differences, and I wonder. I don't know if somebody else knows the answer to this, but I'd be curious. Do we know of the level of spiritual and existential distress for patients in India? There have been some interesting studies, for instance, comparing Scotland to Africa, and what they found was that in Africa, where there's closer knit communities, where religion is a more integrated part of life, that the needs were not the same, and in fact, you know, some palliative care needs were higher in Africa, but spiritual needs and social needs were actually lower because it was so well integrated. And so I'd be kind of curious, you know, not having lived in India, not being as familiar with literature of what the state of affairs is.
Although we don't have any data about the needs of the palliative needs of the patients in India, but still, my own understanding is that the spiritual needs of Indian patients would be much more than as compared to the other societies, particularly when we're talking about end of the life situations.
You think they'd be higher?
I think so. I'm not sure. We need to have some kind of a study to know whether what kind of needs are there in these patients, including the spiritual needs.
I won't know.
So a little comment on this. I mean, I'm speaking on behalf of Nagesh. You met him yesterday on Sunday.
Yeah.
So Dr. Nagesh Simha's PhD thesis was spiritual needs, and he is very clearly of the opinion that Indian patients' spiritual needs are different and probably of a lower magnitude.
Okay.
But even then, they do exist and they do have to be addressed. One way that we will probably be doing that is Karunasha and NIMHANS will set up counseling courses. So if you look at counseling needs of people with in palliative care, you have three broad categories. One is advanced care planning. The second is spiritual support. And the third is bereavement. So we probably will make these as three separate courses. Dr. Santosh Chaturvedi, again, whom you met on Sunday, he and Nagesh will probably work on that through NIMHANS. So maybe we will be able to set up at least some kind of a mechanism which is non-denominational, which is not pertaining specific to any religion. Let's see.
Yeah,
Again,
I could say, in the United States, we, as Par mentioned, we have a bright swath of people with different religions, including atheists. And I would, make it clear that, that religion and spirituality and spiritual needs are separate. That even somebody, who is an atheist, can have demoralization, they can have a loss of meaning, they may have a fear of death. And so I think the needs in some ways kind of transcend or supersede any specific religion. And people who are, Holly Priggerson has actually done some interesting work with people who are Christian, and even among Christians and even among various depths of belief that, that people may have greater or lesser spiritual challenges. And then that neurological illnesses like ALS, like brain cancer, they can challenge people's faith. There may be religious, spiritual issues, but there may be, spiritual issues such as hopelessness, in the face of an incurable illness, or, people wonder why me, whether they believe in a God or don't believe in a God. And so, I think, counseling approaches and figuring out, again, in the Indian context, I'm not sure who would be. In the United States, chaplains are particularly well suited to these things. Because of their training background, but other counselors who have an interest in grief, who are psychologists or social workers, can be equally adept. So I don't think it needs to be a chaplain. I think it needs to just be somebody who's really familiar with the existential challenges that people with serious illness face.
Totally right. Even agnostics can have nihilistic thoughts, probably more actually, then they also need care or something.
Yeah, so a couple of last questions. There's just one that just came in, and I'll just tell you that. I mean, because that needs to be addressed. Somebody asked, isn't palliative care more expensive? So, Benzi.
It depends on the model. And it also depends. So there've actually been a review article, there've been a few, showing that palliative care actually saves money. And again, it all depends on how things are laid out, but the majority of studies that have looked at cost for palliative care find that it saves money. And so to just give an example, in Colorado, for patients from our clinic, the rate of people dying in the hospital is 20%, whereas the general rate is 50%. And it doesn't take very many people not dying in the ICU to pay for a social worker. In the United States, one day of ICU stay is over $100,000. General hospital floor, $20,000. So there's actually interest, and in fact, at Rochester, we're working with insurance companies who are interested in partnering with us because they recognize that if we're looking at things in terms of cost savings, that palliative care is a great deal. So it kind of depends on your economic framework. If you're a hospital that's based on fee for service, palliative care will cost you money. If you're looking at it from systems approach, or you're a health care organization, it'll save money. And so it may be something, that the Indian government or some of the insurance companies may even want to invest in for patients who are at high risk for recurrent hospitalizations, to try to prevent that, because one of the nice things about palliative care is you're doing the right thing and saving money.
Can I add a quick comment, Roop, for this? Yeah, because it's very important in the Indian setup. As you said, their insurance companies may be interested, but here, because majority of the people are paying from pocket, so it could end up in decreasing their expenses also. There's a lot of unnecessary terminal treatment being given because people don't know how to take a decision and how to take an end-of-life decision, and don't have access to counseling. So if you have a good counseling of palliative care available, maybe a lot of patients will end up not paying more for unnecessary antibiotics, ICU stays, and all that. Yeah.
All right, I think we will take this last question and then wrap up. So the last question is how to get rid of refractory pain syndrome and PD. So Benji described various types of, various regions for the pain in Parkinson patient, including your B12 deficiency causing neuropathy, muscle cramps, and dystonic pain, or particularly early morning dystonia. And then you also have some orthopedics issues. You could also have the non-motor symptoms like constipation and the bloating, etc. So pain has different causes in Parkinson's disease, and specifically I'll talk about the early morning dystonia because it relates to the apomorphine, which I have experienced in Australia, now I'm doing in India. So infusion is a different thing, but if you have an early morning pain, which is probably because of the wearing of the lack of sleep benefit, so subcutaneous injection early morning can be beneficial, subcutaneous apomorphine injection. So that's one thing which is very, very useful if you have a particularly early morning dystonic pain in PD patients. Other things, of course, they can, if you find the cause for that, for example, B12 or for example, the other thing. And of course, the advanced PD is a skill actually. The management of advanced PD is a highly skilled, including your invasive therapies and non-invasive therapies. So I would say the pain has its own different regions for that, and that region has to be taken care of. In the last, I think, because this is a COVID-19 times and this is a crisis times, we just published yesterday in the Indian Academy of Neurology a paper on challenges of managing Parkinson's disease in COVID-19 times. So it's available online. It's in the Annals of Indian Academy of Neurology. So that's from our group, and it's quite useful resource of managing Parkinson's patients in the lockdown period and the interaction of drugs and the role of stress and role of social distancing and role of social isolation. So it's a quite useful resource. I would ask group to share if it is possible for.
That was great. I'll pass it on to some colleagues. We've been talking about that and even thinking about writing an article, but you beat us to it.
All right, then if there are no more questions, I think we will close this session today. It has been a wonderful session. Benji, thank you very much for elucidating. Both the talks were very, very useful, and I hope that this session would be quite useful in this